thank you very much. Will this work, or do I have to?
That's for the video camera, and that's for us.
Oh, I see. Oh.
No, sorry about
I
that.
thought this was a karaoke night. So you'll have to warn me if I'm holding it too close to my face. Is that all right? I'm not used to these. Well, some time ago, Victor asked me to do a little talk about advanced care planning, and said that it would be at 12 o'clock, so I very foolishly thought that I would do a little clinic this morning before I came here, and of course ended up with 2 advanced care planning talks in this little short clinic that I was going to do. So I'll try and remember to give you a little example from this morning's clinic of what this is all about. So the reason for this is quite simple. We'll go through why should you make end-of-life plans, who should be doing it, with the patient, when we should do it, and I'll try to give you some clues as to how to do it. Now, this is from a recent document put out by the State Health Service, or whatever they call themselves, Department of Health, and it's about end-of-life planning and all the rest. And Professor Hillman, who's an ICU consultant, made this observation. And most of you will have worked in acute care at some time. Many of you probably still do work in acute care as well as what you're doing. And I think you'll agree this is just an absolute fact. I find it absolutely shocking fact, but that's the case. And the best example of it I've ever seen was on ER a few years ago, when an elderly gentleman who'd appeared a few episodes before having his coronaries fixed was then back with some kind of serious lung trouble. And young Dr. Carter, he was asking that he would get some fancy treatment and go to intensive care and all the rest of it. And Carter, young Dr. Carter, said to him, good communication skills, tell me what you think. So you'd like to spend the last month of your life in intensive care with a tube in every orifice, sir? But that's exactly what this means. Bad things can happen to you if you don't make end-of-life plans. And, I don't know what kind of end-of-life plan was going on here, but it seems to me wrong to take an 86-year-old man with end-stage Parkinson's disease and obvious cognitive impairment to intensive care and ventilate him. But that's what they did twice with the last Pope. And this one seems even worse to me. Remember Ariel Sharon, the president of Israel, who had an intracerebral hemorrhage? I think it was nearly 3 years ago. Well, I checked on the internet yesterday, and he's still unconscious and alive in an intensive care unit. Now, that's not likely to happen with the people we're talking about today, but we have had patients who have been whisked off to hospital here in Victoria and have ended up with a tracheostomy that they never wanted. Because when the paramedics arrive, that's their duty. They intubated this guy, took him to hospital, and before he knew it, he was in intensive care with a tracheostomy. So what sorts of treatments are we talking about? Well, attempted cardiopulmonary resuscitation is the big one and the easy one. And our politicians, both in the UK and here, have stuffed it up for us by saying that everybody has to be talked to about their resuscitation options. I personally don't believe we need to talk to people about treatment that doesn't work. And cardiopulmonary resuscitation mostly doesn't work. And any of you who've worked in acute hospitals or in coronary care units will know that. Less than 1 in 10 attempts at cardiopulmonary resuscitation outside an intensive care or coronary care unit succeed. But the message that comes across from the newspapers and from the television and so on is that you do a few jumps on somebody's chest and lo and behold, they're completely normal again. Well, we know it's not true. And I personally wouldn't do it on most of the patients I look after and wouldn't even bother to talk to them about it. We don't talk to people about an antibiotic treatment or a surgical treatment that is going to work less than 1 in 10 times. Can't hear me at the back. Less than 1 in 10 times. So why would we talk to them about cardiopulmonary resuscitation, which works less than 1 in 10 times? But you may find yourself having to talk about it. More important are gastrostomy feeding tubes, pegs and rigs, radiologically inserted tubes. And we may have more to say about those in a moment. Non-invasive ventilation. We have to talk to the motor neuron disease patients and the muscular dystrophy patients about this quite a lot. It's not going to come up with PSP and so on. Invasive ventilation tracheostomy, that's something. And of course, getting into an intensive care unit and having treatment for some sort of intercurrent illness while you've got some other more horrible progressive neurological illness is something that you might have to talk to people about. Dialysis, transfusion, major surgery, whatever it might be. So these are the kinds of things that you may find yourself talking about. So we need to think about futile treatment. I've already alluded to the futility of attempting cardiopulmonary resuscitation. The VCAT have on their website a wonderful new document, what they didn't tell you about CPR and gastrostomy. And I recommend that you all go to the VCAT website and download it and print it and stick it up on your wall and read it every day, because it's very, very good. But they also emphasize on the VCAT website that it's the treatment that's futile, not the life. And a lot of misconception, a lot of bad thinking and bad talk goes on if you use the word futile, and people think that you're talking about it's a life not worth living. That's not what we're talking about. We're talking about whether a treatment does any good or not. And this is the primary purpose of medicine, and I hope you all agree. We're trying to benefit somebody by restoring them to health and well functioning. Now, we can't do that with most of the diseases we're thinking about today. We cannot restore health and well functioning. We can only help people to manage as best they can with the least harm. And if you're thinking about harms, you need to think about the risks of what you're going to do to somebody, the burden that you're going to give them and their nearest and dearest, and whether or not there's going to be any benefit. You need to weigh up risks, burdens, and benefits. And there's a great deal of knowledge out there about these matters. And of course, we want to do it in the way that the patient wants. They should tell us what they want. Not the son or the daughter or the second cousin or the granddad or whatever. What does the patient want? And while we're doing that, we're also relieving pain and suffering and supporting them as best we can. And I would take suffering to mean psychological, mental, as well as physical suffering. So if a treatment can't do those things, then it's futile. If it can't restore health and well functioning, then it's not working. But palliative care, which is what we're doing down at the bottom, is something that's always working.